Welcome to Endovalve's presentation. My name is Christer Liungman. I am a vascular surgeon since 36 years at the University Hospital, Uppsala, Sweden. I'm also the inventor of the Liungman Guidewire fixator, which is based on an identified clinical need. Over the period of my career, vascular surgery has moved from almost 100% open surgery to 70% radiology-guided, so-called endovascular surgery. This means surgery from an access point in the groin or arm to any artery in the head or foot. This is a large part of what we do. We open up blocked channels to allow undisturbed blood flow in diseased vessels. Here is the bore we use. It's called a guide wire, over which tools and implants such as balloons, stents, and grafts are positioned in diseased arteries. Guide wires comes in all kinds of forms, shapes and sizes and can vary from 40 cm to 6 meter in length, from 0.5 to 1 millimeter in diameter, with different tips, soft, stiffness and so on. There are thousands of variants for different purposes. Over guide wires, tools such as catheters of different shapes, balloons, occluders and implants such as stents and vascular grafts are positioned to treat vascular disease. Disease can be an aneurysm, which is a widening of the aorta that increases with time and ruptures when the tension of the wall is not sufficient to contain an increasing blood pressure. When this happens, death is imminent and the treatment must be immediate. You can see the diameter here is 8 centimeter where it should be 18 millimeter. Guide wires are the runway for a much less risky treatment compared to open surgery, but also unwanted problems such as accidental puncture and very dangerous major blood loss. This is a common problem, and there are methods to control the situation as to the left of the picture, but some patients get severely diseased and lose their lives from this unfortunate complication. The other problem with guide wires is that their position is unstable. They can move back and forth accidentally, even if the surgeon tries to avoid it. Guide wires slip due to tension forces, and the surgeon loses a position that takes time and effort to reach, as seen in this model of the brain circulation. Here is an illustration of the tension forces that affects guide wires. It's often not possible to foresee slippage and loss of position. The surgeon has to start again from square one. Here are some examples of the many tools and implants that are used in vascular interventions. Guide wires, introducers, catheters, filters, balloons, stents, etc. So, vascular surgery is a tool game. It's a lot to keep track on, literally more than 10,000 products. And we aim to add several more. A Swedish radiologist, Dr. Seldinger, invented the method to access blood vessels almost 70 years ago. Balloons for opening narrow arteries and closed arteries, stents and many other tools and implants followed. The market opportunities are extreme. So, we have seen two remaining major problems with radiology-guided vascular surgery, so-called endovascular surgery. Lost guide wire positions means time-consuming work for the surgeon. It can often increase the procedure time by several hours. The second problem is worse. Severe complications resulting in prolonged hospital stay, reoperations, long ICU dependency, and even death. Here is the solution. Anchoring the guide wire to the vessel wall without disturbance of blood flow. The guide wire fixator takes a preset shape when in 37 degrees and gives a limited force to the vessel wall. When tension is applied, a uniform force is distributed to the vessel wall to hold the guide wire and prevent slippage. It offers also prevention for forward loss of position, with the inherent risk of severe complications such as major blood loss. And the flow in the artery remains undisturbed. The Liungman Guidewire fixator, or anchor, is clinically tested, has received CE approval class 3, and undergoes testing in an European pilot study. No complications have occurred so far. The Liungman Guidewire fixator was invented to overcome major problems of endovascular treatment in complicated aortic surgery. It's now used in several renowned university centers in Europe in a pilot study. A simplified stepwise method for treatment reduces procedure time and radiation to the staff. This allows more patients to be treated with less complications. The second generation tool, the filter fixator, offers a much larger market, as can be seen here. It exists as a prototype and it is simple to produce compared to the first generation of the Guidewire fixator. It protects the blood vessels downstream from closure of the outflow vessels by ruptured arteriosclerotic material going downstream during surgery. This is seen on the right. The catheter fixator is a patented solution for precise repeated treatment of cancer and local inflammatory disease. The Guidewire is replaced by a very thin hypotube through which a chemotherapeutic drug can be distributed to a local cancer. A pump for intermittent distribution of the drug is placed on the skin in the upper arm, and the patient can remain ambulatory during a few weeks' treatment at regular intervals. There are a number of very substantial benefits from the use of a stable Guidewire. High procedure risk is reduced, new treatments are possible, reduced kidney toxic contrast need, reduced radiation to the staff, cost saved through reduced duration, reduced risk of severe complications and death, market expansion opportunity through more eligible patients and more hospitals where treatment can be done. Market drivers from open to endovascular procedures, new tool that simplified treatment procedures and reduce time and cost. Endovab offers a completely new technology, the Guidewire fixator, single-use tool used only during one procedure, one technology with at least 3 clinical fields. First product proven and commercially available. Next product, filter fixator, under development. Thank you for your interest in Endovab's projects.